Good afternoon, everyone. My name is Pradeep Goel, and I am delighted to be here today. It's always been a pleasure to work with the GBA and watching Gerard develop this organization over the last couple of years. And it has come a long ways, and it is doing an enormously important job of educating the people who need to understand what this industry is trying to do. And blockchain, as we have heard repeatedly today, does a lot of things. The problem is, what does it really do well? And there is so much possibility that we get lost in the art of possibilities. So for the next 15, 20 minutes, I'll talk to you about the art of done. So we can talk about what actually blockchain did in healthcare so far, and that hopefully serves as a roadmap to doing a lot more things. So I'm going to spend a bit of time about what SolveCare has done, but I'll do an introduction to blockchain in healthcare. Gerard asked me to make this a lesson, a tutorial, which is very difficult to do without getting into technology concepts. And he prohibited that I not use technology concepts, so that's a particular challenge. But I will do my best to simplify a very complex topic. So let's move forward to the next slide. So I've been in healthcare all my life, 30 plus years. You can call it a blessing or a curse, depending upon the day and the hour. But I have worked in healthcare now from many different angles, and I've seen, as you would kindly say, the underbelly of the beast in context of how it works and how it doesn't work. And one thing we can say very comfortably is that it doesn't work as well as it should for patient and doctor. There are a lot of players like me in the old chair of Blue Cross CIO or Medicare or Medicaid administrative agencies or fiscal intermediaries or contractors. We do a lot of things behind the scenes to keep healthcare working. But in the end, when you ask the patient and the doctor, at least for the 35 years I've been in healthcare, have things gotten better? The answer is not really. They haven't really gotten better. And why does that doctor and the patient perception linger, despite trillions of dollars spent each year? And to put things in perspective, healthcare is $8 trillion a year spent, right? $4 trillion in the US, $4 trillion worldwide. And yet we keep talking about these goals and never seem to achieve them. Better outcomes for the patient, better experience for the patient, lower cost overall, and more effective physicians. Seems pretty simple, right? I mean, how hard can this be? Apparently, it is hard enough where we spend billions and billions in trying to connect systems, and in the end, interoperability never really seems to deliver better care. So we have agencies, organizations, entire ministries of health worldwide trying to achieve this quadruple aim, and yet we struggle. So the reason for that struggle is that because we have, can we move to the next slide, please? And by the way, this slide previously was not a US slide, there was a Qatar, government of Qatar slide. You could replace any government name and you will see the same slide on their healthcare policy. Saudi Arabia Vision 2030, or the Ministry of Qatar, the Indian Health Authority, of course CMS and HHS in the US, they all talk to the same 4 goals, and we all talk to them like we're talking about landing on Mars, which looks closer to reality than fixing healthcare, which is kind of ironic. But this is the picture we see in how many variations. Somehow, magically, we're going to put the patient at the center, and we're going to have everybody collaborate around this patient as a team. Doctor, pharmacist, specialist, home care, family members, therapists, everybody will collaborate, and we will focus on the patient. That's the picture that every government policy initiative is built around. Let's move to the next slide. Here is the reality. The patient is not in the picture. So when I joined Blue Cross, I had an interesting meeting. We were sitting around and talking about what we should do as a board meeting about what we're going to do as an organization to improve healthcare. And we talked about this entity called beneficiary. I didn't know who a beneficiary was, but we kept talking about the beneficiary. And I said, well, what about the consumer or the patient? They're like, well, that is the beneficiary. He's the beneficiary of our largesse. We give this patient the right to get health care. We offer them benefit plans and privilege to exist. I'm like, what the heck? How are we as an organization going to ever be patient-centric if we don't even call the patient a patient? We call them a beneficiary, almost like a freeloader. A beneficiary of what? They bought insurance from us. We're supposed to give them a proper risk-managed product. So the point is, it's not intentional, it's institutional, it's systematic. Okay, patient isn't in the picture when we design systems. I was in this room many years ago during the ACA, and we were having meetings and conferences about how we are going to really improve interoperability. You know, all the big guys were in the room, McKinsey's and IBM and of course, a bunch of government people and crazy IT patriots like me who thought, oh, we can fix things by working in the government. And none of that was really about the patient. We all talk about interoperability of hospital systems to clinics, to pharmacies, to insurance companies, but there was not even a thought about what the patient access point would look like. And then, of course, healthcare.gov came out and wasn't a great launch because that was the only consumer access point that we were building. And why did it fail? Because we had never built a consumer access point for healthcare before. It's that simple. It wasn't a website. It was the idea that consumers can have a role. And suddenly everybody's like, oh my God, who is this person called consumer showing up in my ecosystem? So we're not used to treating the patient as a center of anything. Let's just stop kidding ourselves at all, completely. Having said that, I left Blue Cross to come to do solve care because I figured the next 30 years of my life should be about making a difference. So that's the vision and mission behind what we are doing, but that's not the point of the meeting today. The point I want you to understand is how can blockchain work and how does it work? So let's move to the next slide, please. I'll cover a few more stats which will help illustrate my point. US healthcare spend compared to the rest of the world, 50-50. We spend half the world's annual spend on healthcare, 8 trillion, 4 trillion. That's about the general math, depending upon who you ask. Next slide, please. Outcomes do not get any better. Okay? We haven't seen really any significant statistical movement in life expectancy. We haven't seen any significant improvement in terms of child mortality rate. We haven't seen any real significant improvement on any kind of a chronic disease spread or prevention. The percentage of diabetics in this country is off the charts. And that's not just a US problem, it's a global problem. So what have we really done? A precious little in terms of actually making the impact. So let's move to the next slide. What are the real issues here? The real issues ultimately boil down to, if I can summarize it for you, I'll bring it to one point. In healthcare, custody of data and ownership of data are commingled. Whoever has your data is the owner of your data, which means that as a patient, if I go see a doctor, first thing I do, I'm sure some of you might remember this, you walk into the doctor's office, the first thing you do, you sign away your HIPAA rights. You give them that consent form. Do whatever you want with my data, doc, as long as you take care of me, right? And then you never go back and ask, what did you do with my data? Ever. You never go back and revoke that consent. I don't know if any of you have ever gone back to the doctor's office and said, hey, dude, that HIPAA form that I signed, what's happening with it? Who are you sharing my data with? You trade care with privacy immediately, day one, moment one, in the lobby of the clinic office, you first give away your rights, then you're treated, right? Then we talk about HIPAA as a bedrock principle, but reality is we have to immediately give it up before we get treated. And after that, it's whatever happens in the backdrop. So the patient doesn't have the data to be engaged. Okay? We can talk about patient engagement all day long, but they don't have the information to be engaged. They don't have cost information. They don't have their medical records. They don't have comparable information about quality. They don't have comparable information about the choices. So how do you want me to be engaged? How? If you can come up with the answer, I will be outside and I'll be waiting anxiously. The problem is that data is stored in silos. As a Blue Cross, I had my huge database, Teradata, big warehouses, member information, claim data, ICD, CPD codes, more jargon that you can throw a brick at. None of that was accessible to you. I, as an insured member of my own company, could not access the data that was sitting about me in the system that I controlled. Right? This is the nature of healthcare, not just in the US, but worldwide. Data is power, and healthcare has been enormous power for a long time. So that's one. The same problem the doctor has. They don't have any more data than you. Here's a dirty secret I want you to understand. We all talk about medical records, right? You got to keep your medical records. You got to have them with you if you want to change doctors, hospitals. Healthcare data has a half-life of 90 days. After 90 days, that data is largely useless. It's half as useful. Another 90 days is completely, utterly useless. Doctor's not going to do analysis and prescription based on 188-day-old data. They can't, because things change too quickly in your human body. So health data has a very short shelf life. 90 days is about the realistic usage of data. After that, it just becomes a trend line. So if you have a trend line, you don't need the data. If somebody can show me my A1C chart for the last 18 months, they don't need to see the actual results. They just need to see the trend. All they care about is what's been my A1C in the last 30 days, the last 2 weeks, yesterday. So healthcare data loses value very, very quickly unless you aggregate it, analyze it, and monetize it, which of course the patient never does. Of course, a pharma does it, insurance does it, government does it, but you don't. So your data value is only about 90 days long. If you have your last 90 days worth of information, you're good to go in most places for most conditions. Unless, of course, you're dealing with a multi-chronic, life-threatening mortality issue. Those are exceptions, okay? So the pain point is ultimately around data and information that is actionable. And how can blockchain really solve that is the real promise and the real challenge and the question in front of the regulator. So let's move to the next slide. So I want to show you some examples of how we might use blockchain and how we have been able to use. We collectively can use blockchain in many ways, and we SolveCare have used it in some very specific ways to solve some issues, which I hope will serve as a role or as an example of what actually is achievable in the current state of affairs with the current regulatory environment, with the current limitation of technology. But those are the 5 areas we focus on: timely access to care, enforcing patient rights, ensuring that the data ownership is not equal to custody. Custody should not be equated to who has your data, but custody can be controlled remotely, and that's where blockchain becomes very interesting. And then you achieve effective coordination, interoperability, some agility in systems, and actual physician efficacy. You only achieve that efficacy if you first address the first 3 things. So next slide. I want to show you some examples. So what we believe from experience of having built a lot of IT systems in the blockchain in an OSI stack, those of you engineers or recovering engineers like me, most application stacks have layers, right? You have the operating system layer, the hardware operating system, database, business logic, identity, consent, transaction state management, payments, and some kind of a UI, UX, website, portal. So you typically have this stack. Blockchain is not a stack. I want you to walk out of here with one simple fact. Blockchain is not a stack, it's a layer. It solves a very specific layer problem, but it's not a solution. You're not going to take blockchain, drop it into an enterprise like mine in the past, and say to me, Pradeep, go forth and prosper and now deal with your members, your patients, your doctors, your pharmacy network. No, it doesn't do that. It's a layer, but it has very clear properties you can build a system around. The properties are, it's immutable. Whatever I write into this layer will not be deleted. It's easily replicated, so I can make this layer go horizontal across different stakeholders, right? And it's highly auditable, which means I can verify what happened, when happened, in the context of what was written to the blockchain. That's the 3 properties. All 3 are very valuable in healthcare, but those 3 properties does not get you to a solution. You still need identity management, consent management, business logic. You still need a user experience interface. You still need a place to manage transaction states, because data isn't a system. Systems consume data. So you don't want to think of blockchain as a car. Blockchain is like a transmission. It needs to connect to a gearbox and needs to be driven. Otherwise, it's just a technology play. So when we think of blockchain's potential, in some ways, I think of it as like the database revolution that came around in the 60s, right? The whole client-server technology, the RDBMS technology came out. People started asking, what can I do with this database? And then on the strength of that, we built a lot of things. All that current commerce, predating internet and post-dating internet, is all based on a database technology. Very transformative, right? Same thing with blockchain. It's a data sharing technology. It's a technology that helps you solve very tricky problems. But in itself, it's still a layer in a platform. Next slide, please. So you do need some kind of an access point to the blockchain, right? You're not going to be able to just use blockchain in its native form. You have to give the consumer, the physician, an access point. In healthcare, that's really important, because access point is typically multi-party. You have a doctor, a patient, a pharmacist, a therapist, a home care aide, and so on and so forth. So there has to be an access point. The most common access point that we have seen is wallets. We are starting to see more and more and more variety of more consumer-friendly wallets. Most of them are around payments. But if you take that concept further to whatever industry you're in, and you can think of as a consumer wallet, where they can not just move money, but they can transact with you. If you start thinking of Amazon app as a blockchain wallet, then you will start to see where we have to get to. You need something more than just transactional capability. You need information, consent, identity, and payment capability. And that's the next generation of wallets that we will see inevitably over the next 12 to 18 months. And what you have to be able to manage through the wallet is who you are, what consents do you give to for what information you want to consume and use, what events you're willing to process through your wallet, and what events you want others to respond to when you take action in your wallet, what transactions have you completed or are pending in your wallet, what payments are you willing to receive and send, and who do you want to share your information with. If your wallet does those things, then you're talking about something real, something usable in the market. Otherwise, you're talking about blockchain as a enabling technology and what it's art of the possibility. I'm trying to get you to think about the art of doing. The art of doing here is use blockchain as a layer which has certain very unique properties, build a full platform stack around it, put it in the right place, layer 3 in this case, and then build proper access point, a wallet. Next slide, please. So using this philosophy, we have implemented some very interesting real-world use cases, 5, that I want to share with you. And then I'll let you ask questions, because we can go on for hours and hours. I can give you a lecture for 18 hours, and you will be looking for a place to escape. What we did is first network we built using this blockchain technology is transportation subsidy management. Very exciting stuff, very, very high-tech stuff. Reality is in every state, Medicaid operates a subsidized transportation for those who can't afford to get to the doctor. So basically, I go make an appointment to a doctor, and then I call the Medicaid agency and I say, hey, I have a doctor's appointment on Monday at 11 a.m. and I need a transportation voucher. And something arrives in the mail. It's a voucher with a phone number to call to make a taxi appointment. And then I give that voucher to the taxi driver on the day of my trip. And then I go see the doc, and I have another voucher to come back home. Except I decide not to go to the doc, and I sell that voucher in the market and get a pack of cigarette, and I end up making my emphysema 10 times worse. But that's the problem, that these vouchers are highly tradable, non-digital currency in the black market, but they're money. So we built a system where this kind of a coordination of benefit can happen using a digital voucher, which is linked to an appointment, which requires a physician to say, yes, I have an appointment. I issue that event. I get a digitally signed certificate or a token, which I can use to actually automatically send to Uber or Lyft, and they will book my appointment, and I can only go from point A to point B. And if I cancel, the token gets returned back to the issuing authority, the Medicaid agency, on and on and on. It's a use case of blockchain, very interesting one. We estimate that every state can save between $30 to $50 million a year in wasted transportation benefits. Not to mention another $30 to $50 million a year in administering those benefits. Because remember, only in healthcare can you spend more money on the payment of the transaction than the transaction was worth. I have never met an industry where the cost of buying a sweater, the card swipe on buying an equivalent of a sweater in healthcare can be more than the sweater itself. That's what we call claims processing in healthcare. I personally have seen us spend more than $35 to pay a bill for $25, right? So in healthcare, there's a lot of inefficiency. This is not just a US phenomenon. US just happens to be the most widely monitored and washes its laundry in public, so we all get to see it. But it is true, those are the issues in most healthcare systems. So we built this system around the idea of using blockchain as a coordination of benefits chain. And it was, from a trial perspective, from a partnership perspective, it was very effective in not just reducing costs, but actually getting people to the doctor. Because the whole process becomes highly streamlined. But it won't work if a sick person doesn't have a quick, easy app in their hand. They actually don't know that they're using a blockchain system, and they couldn't care less. All they want is the government to pay for their ride to the doc and back home. Or they want to be picked up from work, go to the doc, and then get a ride back home. And there's a lot of complexity here, but the point is it's a valid use case and it works. Next slide, please. There's another use case we've implemented, which is called value-based care. Very fancy term for saying we're going to pay the doctor for making you feel better, right? The idea of value-based care, if you are interested in healthcare, and we can talk about this later, is that let's not pay for visit to the doctor, let's pay for outcome. Let's pay for, the old Chinese proverb, pay the doctor who keeps you healthy, not the one who keeps you coming back for more medication. So value-based care in many simple ways is saying, let's pay the doctor for a total care outcome rather than for episodes of care, encounters or visits. So in that model, the payment of the doctor got linked, automatically sent using digital tokens. It wasn't just about sending a digital token to the doctor as a payment. That's no big deal. Exciting as it might be, it's no big deal. The idea was to link it to things like, did this doctor do Pradeep's annual checkup on time? Did he send enough reminders? Did he make sure his A1C stay inside the acceptable boundaries? Did he ensure that his prescriptions are filled on time? Care events linked to payment. And if events happen, you get paid. If events don't happen, you get paid less. Simple enough, very complex to do, but a real use case. Savings into the hundreds of millions a year in a small 50,000 cohort of patients. Imagine what we can do with billions of people. So the issue that the opportunity here is you don't have to wait for blockchain to evolve into some appropriate panacea. There is low-hanging fruit in every country. I want to talk about the third use case. Can we move to the next slide, please? So our third network we've launched is a global teleconsultation network. Now here is the premise. The premise is that if I want to see a doctor, if my grandmother lives in India, and I want to pick up the phone and call her and say, you know, my son is not feeling well, what do you recommend, Mom? She will tell me some remedy, and it's my choice as a parent to use that remedy or not, right? There's no law against that. But there's a lot of laws against me picking up the phone and calling a doctor in India and saying, hey, Doc, you're a well-known pediatric physician, and I want to understand, how would you treat my kid if he was in India? All kinds of barriers, and it's impossible. How would you even find such a doctor? How would you even know they're good? Why would you choose this doctor over your local doc? Well, those of us who live in privileged societies like US or the G20, don't worry, but those of us who live in societies where healthcare isn't that accessible, that is a question. I don't have a local doc who's qualified. What do? Well, I go to Granny or I go to the village elder and ask for advice. That's my doc. So how do I find qualified doctors? So we launched a global teleconsultation network with the idea that give patient the choice, give the parent the choice. And I give you a personal driver for that. So a few years ago when my son was born, he's 7 now, almost 7 now, he had some cognitive disabilities, and I wanted to see if there is a better way of treating him than the one that the doctors in Florida were recommending, because I didn't get it. I didn't get that there was no treatment. How could you not have a solution? So I started to research, and I found a pediatrician in Sweden, and I spoke to them, and they gave me a slightly different treatment model. And we followed it rigorously. And now the results are amazing, amazing. How did this happen? The local docs are unclear how we pulled this off. It's because we did research and we made a choice to look elsewhere. Now, I had the resources to do it and the healthcare experience to do it, but most parents don't. So we want to open this access up. But how do you do it in a regulatory environment? Well, you got to build very clear regulatory relationships between patient, doctor, second opinion, third opinion, consents, payments, very complex. But blockchain makes it possible. So we've launched this network in 20 countries, not the US, but 20 other countries where doctors and patients are intermingling and connecting with each other. After doing a lot of research and looking at where the teleconsultation laws are, where the cryptocurrency laws are, we were able to launch this network where 20 countries, patients can talk to doctors in any of those other 20 countries and have meaningful legal consult. That's good. That's a starting point. I want to get to 200 by 200, right? 200 countries of doctors and 200 countries of patients to connect them all together. There is a use case because it actually improves access to care. Imagine being in a pick any underserved nation, Bolivia, Peru, Colombia, where I was recently. There's always an imbalance between demand and supply of healthcare. So if we can rebalance it, we can save trillions. Here's another fact for you to consider. Even though we spend $8 trillion a year on healthcare, there's about $1.5 trillion worth of healthcare we don't deliver, meaning people want care, but they can't find a doctor on time. A couple of more facts to consider. In the United States, if you want to see a specialty doctor, 1 out of 4 times you will wait a month. 1 out of 4 times. 25% of the time you will wait a month. But here's a startling fact. If you're in Canada, you want to see a specialist, you will wait 1 out of 2 times you'll wait for a month. If you're in Norway, 6 out of 10 patients will wait for more than a month. A month. Your body doesn't wait a month. But that's the true case of highly developed nations. A month wait is not uncommon for specialty care. And we all know the reason you need specialty care is not because you want to go to a fancier office, because you really need care. Because normally a primary care physician should have been able to deal with it, but you got something seriously wrong with you. Therefore, you need to go see a specialist, and you're waiting a month? What is that impact on acuity and cost and human suffering? We can't calculate that. So we need to think more fundamental. And somebody said earlier, I believe, the blockchain is like wind and air. Governments can't regulate it. We have to leverage that property for good things. So if we can use a blockchain-based system to connect patients and doctors better, it's a good thing for humanity. And it's financially ridiculously lucrative. Because we've identified there's $1.5 trillion worth of unmet need in the healthcare space, where if you actually gave them a solution, like your access network, they would actually spend the money. So talk about creating value. Right? It's not just about reformatting the insurance payer-pharma relationship. It's about actually serving a need. Like the unbanked, they're unserved in healthcare as well, and they're about as big. So there's a lot you can do there. Next slide, please. So what I want to talk about here is how do you do this? One of the things that blockchain does do really well in healthcare is actually enforce things like HIPAA. Sounds weird, right? But actually what we have discovered is that when you talk about the intent of HIPAA, let's put away the jargon. What does HIPAA say? HIPAA says patient has right to their data. Patient has a right to tell you how you can use that data. And patient has a right to take away that consent when they feel like you're not using that data. And you must protect patient data at all times. You cannot sell it, you cannot use it, leverage it for your own benefit. You certainly can go on the side of the street and put it on a billboard and say, I was treating Pradeep for cancer, so here is his medical data. It's protecting my privacy, it's giving me some rights, except we give away those rights in the first minute of treatment. But those are your rights, except they're traded off between you getting care or not getting care. So in blockchain, you can actually do things that allow you to manage consents. So one of the things that we have discovered, and I challenge you to study this more or come and talk to us, is that you can actually enforce consent much better on the chain. We can track consent, and you can revoke consent. What a novel concept. I want my doc to stop using my information. They have no more reason to use my information. I'm not going to go see this doc again. I've switched primary care physicians. My previous doctors, I should be able to go in my wallet and simply remove consent from all of them. And it should happen by default when I switch my primary care. I shouldn't have to even do anything. My wallet should remember that, hey, you have switched primary care. You have primary care physicians with consent from 7 years ago. Start disabling all of them. Why do you need them? Why do they need to have access to your information? For what reason? And gather all that data, because they are custodians, not owners of your information. So there is a real way to implement the intention of HIPAA, not what it has become, a parody of what the law actually meant to say. You can do the same with GDPR. There are technical issues, but the thing is, blockchain is not just replication, it's also encryption. Remember that. What is blockchain in the end? It's a replicated, encrypted messaging system, is what a blockchain is. A blockchain node sends a message to another node saying, here is my events, here is my peer-to-peer messaging, this is how we discover each other, this is how we talk, this is our encryption handshake, and if you compute the same result as me, we are buddies. We are in sync, we have consensus. That's all blockchain is in the end. So you can leverage that property of consensus to actually ensure that consent moves back and forth between nodes. And that's, I believe, the real use case in healthcare and in finance and in social media and in gaming that one very energetic speaker spoke about earlier. It doesn't really matter. It's all the same in the end. So compliance, privacy, and rights actually are implementable on blockchain because they are bilateral, not unilateral. Your rights aren't enforceable if you give them away. You need to have control over your rights, not just as a trade-off for treatment. So we found that you can actually do that. You can actually give and take consent away in blockchain. You can actually record the event of consent. You can record the event of revocation. And you can time box those two events to say, all the records created between this time box, this doc can see. All the events created outside this time box, only I can see. What a novel concept. Right? So those are the things that lie underneath the opportunity here. Next slide, please. So I won't bore you with this, but 3 use cases we have found fundamentally. Care coordination. I forgot to mention this, and there's not enough time because we compressed my time a little bit, and we can talk later. Care coordination. So we have launched a network around diabetes care coordination. And that was built in partnership with Boehringer Ingelheim, which is a major pharmaceutical company, and their mission and vision is to really make diabetes care more patient-centric and to bring it to US and to India. So this diabetes care coordination, just an example. We're also doing pediatric care coordination, suicide prevention in India, all on the same platform, all of which relies upon the same properties of blockchain. So that's one side, care coordination. The other is care administration, the boring stuff that I used to do. Plan management, benefit management, payment management, network management, enrollment, eligibility re-verification, things that you do to make sure that the right people get the right benefit at the right time, the beneficiary concept. Right? So that's the care administration side. Lots of use cases that make sense. And the last one, of course, is payments. And we're not just talking about moving money from point A to point B. We're talking about linking money movement to right outcomes, to the right behavior, to the right series of events. If X follows Y follows Z, money will be paid. If X follows Z follows Y, something else will be paid. And if X follows, if Z follows X follows Y, we're not paying because something went terribly wrong. And then we'll audit and we'll investigate. So you can automate, you can program money. But really, when you say you're going to program money, what you're saying is you're going to program the events leading to the payment of money. And that programmability is what we are talking about here, so that you can automate the payment transfer based on certain events that are immutable, cannot be disputed, therefore they can be paid. That's the concept. So those are the three fundamental use cases in healthcare. I'll repeat them because they're worth repeating. Care coordination of chronic and multi-chronic and acute care, administration of benefits that underlie who's going to be responsible for what payment to whom, and actually making the payment based on outcomes, not just events. Those three things address almost all the core issues that lie in front of governments, in front of insurance CIOs and CEOs, in front of hospital systems, and in front of patients. So what I'm trying to summarize for you is, let's take the blockchain out of the abstract, and let's talk about how in healthcare it is going to actually work. And if you focus on those three pillars, you will find plenty of use cases, plenty of revenue, and plenty of gratification because you will actually make healthcare work better. Thank you, everyone. I'm more than happy to take your questions.
What's the current pushback that you're getting from the industry in terms of barrier to adoption?
So it changes year to year. Pre-pandemic, it was, of course, the conflation of blockchain and Bitcoin. That this is, the most important concern was that that data is public and not controlled. Because blockchain's property of encryption is not understood, right? That it's an encrypted event-based messaging system. And underlying that is all these nodes that are talking to each other on an encrypted channel. And they are agreeing upon a pre-agreed formula of consensus. That's all it is. So that used to be the big issue. Now the issue, of course, is post-pandemic, how do I deal with the current issues of the day? How do I get improve access to care? How do I keep patients safe? So I think the conversation has largely moved from, is blockchain a viable solution, to tell me how you're going to actually make it work. And the number one issue that we hear now is user experience. I hear that blockchain is very hard to use, and they're right in having that concern. Because the way we as a technology, as an industry, have talked about blockchain is we made it very developer-centric jargon. And I'm a recovering engineer. I'll never fully be not an engineer. And I love engineering because I think it solves fundamentally issues, makes the world work better. But we need to communicate that blockchain does have and will have more access points. And if you think about the big success stories in crypto world, like Coinbase going public, when you ask the market why them versus other exchanges, well, they made it easy for you to have an account, to be compliant. So I think in many ways, we follow the same trajectory. My vision is be compliant, but be accessible. You can't say one or the other. You can't say, well, I'm compliant, but in such an arcane manner that only 3 people on the planet can figure out how to get into my chain and use it. Then it won't work.
Yes, I have a similar question that when I asked Mark Montoya. So given the extreme fragmentation of regulation in healthcare space, for example, in this country, a doctor licensed in one state cannot help a patient from another state. How do you combine that with the global nature of blockchain and with some of the interoperability things that you talked about before? It seems like a great conflict.
Thank you for the question. Exactly. So it's the two sides of the same coin. There lies the opportunity. So yes, healthcare regulatory environment in the US is state-based. In most countries, it's national in nature. But cross-border is very fuzzy. We did a survey of 90,000 physicians approximately across, I think, 80 countries to try to understand what is their day like, what is their regulatory requirements like. And from that, we discovered that there are clearly spaces where nobody has yet gone. And as you spoke about, you can find the wind to blow through the cracks where there are. But having said that, if the intent is correct, if you're demonstrating that you are protecting patient data, you're putting in consent mechanism in place, that you have traceability and auditability of everything, then going into uncharted territory is a little less scary. So having said that, we have only launched in 20 out of 200 countries, because there we could understand that either law exists or law is completely absent, those two extremes, where there is total silence on whether a patient can consult with a foreign physician, or they have already built a consortium mentality. There is a lot of, there's a macro trade pact between India and a bunch of African countries where they have basically credentials. If Indian physician is seen as a local physician per treaty, right? In the US, in the state-based model, there's a medical consortium around multi-state consortiums that are developing, which are saying, I'll accept neighboring physicians. I used to live and work in North Dakota, and we used to have the similar relationship with Minnesota, because there were not enough doctors in North Dakota. Many consortiums are emerging, and they will inevitably occur because there's a demand-supply imbalance, right? And then eventually they'll coalesce into a bigger ecosystem, and we are accelerating that. But the answer is, you need to understand the law, configure the law into your system so that you can show compliance with it, should and when a regulator come asking. But if the intent is correct, if you can demonstrate that the data was protected, encrypted, shared with consent only, and used for the purpose intended, then there's a little to worry. So that's where the blockchain helps, don't take my word for it, look at the chain. That's where the protection comes.
Could you address clinical research and some translational medicine, how it fits in with what you're doing?
It's a very exciting space. I am not that involved in it currently, but we have seen a lot of proposals from companies who have come to us and said, we would like to build a clinical research model on our system. And our view is, take it and run with it, right? Our whole point here is we can only do so much as a company, and our platform is available to those who want to innovate in healthcare and change the world for the better, one patient at a time if it needs to be. So this idea of a patient-elected participant model, where patients elect into a clinical research, where you can have a larger cohort of physicians who join into it, perhaps either as investigators or as auditors, and that everybody has an appropriate monetization of their role. Patient gets monetization of their data and participation in the clinical research. And most importantly, in this particular case, the excitement is around continuity of care post-research. Because when somebody comes into a diabetes care study, they probably have diabetes. Pretty safe conclusion. And from that, once they participate in the study, what happens to them after the study is over? How does their care continue? So those are the very exciting opportunities where you can coordinate patient, doctor, investigator, auditor, and primary care physician post-study into a play. So it's a very good use case. We haven't done it yet, but we have companies who are doing it on our platform. Yes, sir.
All right, we have just time for one more.
So the largest legal cartel in the world is the American Medical Association. In terms of pushback from them who try to manage supply, what kind of concerns or, I don't know, what type of sounding are you getting from them?
So, look, I think while I understand why one would label any large organization that sets the rules for the rest of us as a cartel, they perform an important function, obviously. What we have focused on is essentially enabling the physician to perform better, which is not really a very controversial topic. We've also focused on expanding the physician's availability to non-US citizens, right? In saying that, look, if you wish to practice outside the boundaries of the United States, you have a safe platform on which you can have appropriate consent, pre-consent, pre-treatment and post-treatment consents, everything done for you, and in a manner that you don't have to trust me, it's all on the chain, so you are protected. And the patient has indisputably given you that appropriate authority to treat them. Whether you can write a prescription or not is another question. So those kind of things are physician-friendly. So our view is that if we create value for the physician, then the AMA will ultimately listen to their body of physicians, right? But by no means we feel that we can, as a technology platform, trying to improve things can drive the mindset of AMA unless we deliver value. So the value creation is better access to patients they already have, right? Simple, concrete example. A primary care physician normally has a panel of about 2,000, 2,200 patients, but only about 400, 500, 20% are active. The remaining are just not sick enough yet to show up at your office, or they just aren't attuned to their missed opportunity of exams and checkups and whatnot. So if we can take that 80% that is passive but in need of care but is not getting care, it's good for the doctor. It's increased revenue. It's good for the patient. It's better outcomes. And it's good for the AMA in that regard. So we have tried to find use cases where we are actually serving the purpose we all claim to serve: better patient care, better outcomes, lower cost. And then it becomes a little bit easier to have a conversation that, tell me what I'm doing wrong, right? So in that regard, you have to be very careful that your use case actually speaks to clear value proposition. And if that is delivered in clear empirical data, then you get a lot less. The resistance tends to fade then over time. Well, thank you, everyone. I'll be here for the rest of the day. Look forward to. Appreciate your time. Have a great rest of the day.